Good afternoon to everybody. So phase 2 multi-center study of Natalizumab plus standard steroid treatment for high-risk acute GVHD, and this is the SIV. So I'm going to be talking about the background and rationale for the study objectives, the patient eligibility, the screening process. How many minutes do I have? 1 hour. The screening process, the research sample collection process, the trial design, the treatment plan, the safety monitoring, and the conclusion. So background and rationale. So ANOVA scoring. What is ANOVA scoring? ANOVA scoring was developed and was shown to predict the probability of non-relapse mortality at 6 months from the onset of acute GVHD. So in terms of background, this is definitely a totally different way of looking at graft-versus-host disease and gives you an opportunity to diagnose it and predict without having to look at the clinical manifestation of the disease, which has been very difficult to use for prediction or even response to treatment. So the current system that we have is the Glucksberg system, which is a clinical grading based on how the disease presents itself. Just to remember, it's a retrospective system. It does not predict well the treatment response, and it's done at diagnosis for the beginning, and then when you have to redo it. So it always has been a struggle to use it to guide how we treat patients and how we escalate or de-escalate treatment. So the ANOVA scoring was developed through plasma biomarkers. Different biomarkers have been found for GVHD. The best predicted model was based on TNF-alpha, which is a TNF-alpha surrogate. REG3 alpha, which is a GI antimicrobial peptide and correlates and predicts treatment response, and also ST2 levels that is related to treatment resistance for GVHD, as well as death without relapse. So through the ANOVA scoring, 3 different scores were identified that could correlate with different levels of non-relapse mortality. ANOVA score 1, non-relapse mortality up to 10% at 6 months. 2, which is an intermediate level, non-relapse mortality of approximately 25% at 6 months. And the ANOVA 3, which is a non-relapse mortality of more than 40% at 6 months. ANOVA scoring for each one of the Glucksberg. I think this is a very important slide. So as you can see here, I have the Glucksberg 1, 2, 3, and 4. So this is considered to be a benign disease in terms of clinical manifestation of GVHD. And I want to just draw your attention to the fact that within each one of the Glucksberg grade, I can stratify those patients that present clinically 1, 2, and 3, 4 as being ANOVA 1, 2, and 3. And if I look at the proportion throughout those different clinical grading, you're going to see that they all divide in very similar percent. And so throughout those different clinical manifestations. And they have also, when I look at the response rate at day 28, which is a surrogate marker for later death, and that's how we assess, right, long-term survival for those patients, you're going to see that they're also very different for the ANOVA scoring. So important to mention here, I have clinical grading, which does not correlate with the same thing, and also with response. And my ANOVA scoring is able to tell me quite confidently how those patients will behave in terms of response to the treatment I'm giving them and how they behave in the long term. So if I look further down, I can see that this here is a population that I could target because they are very high risk. In red, this is my ANOVA 3 cases, and those are the ones that have a non-relapse mortality of more than 40% at 6 months. And they have also a lower response rate, which is also quite similar across the different clinical grades, at day 28. Very interesting also is that the Ann Arbor score is able to predict the lower GI GVHD for patients that present with isolated skin presentation. So how did it work? So those are 286 patients from Michigan and Regensburg. Those patients, they were just presenting with only skin manifestation. We're going to compare how they do an Ann Arbor score and Glucksberg stage, but I want first to show you that those patients, when you look only at the skin, you can divide in some way, but when they look at the biomarkers, they saw that within the skin only manifestation, they had a risk stratification based on the Ann Arbor score. That was significantly different, which is not true for the clinical.
Any skin, skin 4, skin 3?
So those are skin less than 25% BSA, 25 to 50, and 50%, and they only had skin manifestation. That's it. And interestingly also, those patients in the Ann Arbor 3, when you look at this population here, you had a higher risk, which is the number, exact number was 1.78, risk increase about two times more likely to develop GI, GVHD than the other patients. And the median time for that to happen was about 12 days. So that tells you that the patient presents only with skin, and about 12 days later, they will have GI.
So just on the Ann Arbor score, patients who present with 1, 2, or 3 Ann Arbor, with those risk scores, when they have skin GVHD numbers, my question is, what kind of skin GVHD? What's the grade of the skin GVHD? Is it any skin, grade 1 skin, and a score of 3, they have a 30%?
So this was done with patients that only present with all grades of GVHD skin.
So grade
This is the breakdown.
1, 2, whatever BSA. I don't have the breakdown of, I know what you're meaning. So Eileen is asking,
If somebody presents with grade 1 GVHD, I'm just asking what grade of skin.
they had to be, if we can actually subdivide the skin in having 10%, and they were more likely to be an Ann Arbor score 1, that's what you're asking?
Just go back a slide.
I just want to know, you're saying.
So that, we don't have the answer to that specific analysis,
Right.
but it's implied by this. So those patients who had Glucksberg 1 and Ann Arbor 3, they have 40%.
That's what I'm asking.
60, 50%.
So this was skin.
60% on the other.
No, this is not
Oh, this
skin,
is
this is
overall.
Overall.
But
Overall
then they
Glucksberg
did-
1 was the 50%.
Right.
Area.
Exactly. That's right.
So I'm not.
But we don't have exact numbers for that. Ann Arbor trumps the Glucksberg. That's exactly, I think, the point. And not only that, it tells you that some people, some patients that are there only with the skin, about 10 to 12 days later, they can come with, they have a high risk of developing, they have a risk. About 50% of them will end up developing GI GVHD, which is not predictable with Glucksberg. And that's exactly, when you see that maybe you could target these patients, even ahead of time and try to target them before they develop a steroid resistant or whatever immunosuppression resistant disease. So in summary, Ann Arbor score 3 GVHD identifies a high-risk population across clinical severity presentation. Ann Arbor score 3 is about 22% of mild, moderate, or severe GVHD, as I showed in the other slide. Those patients, high rate of primary treatment failure. Only 30%, this is not in the slide, CR, complete remission. 45% 6-month non-relapse mortality, poor survival in the long run. Treatment failure is primarily due to what? Poorly responsive GI GVHD, as we know that, right? So GI GVHD not present at onset in about 50% of those patients that are Ann Arbor 3. So as I said, ideal opportunity to test biomarker, guided GVHD therapy. So it would also include those patients that are Ann Arbor 3, not yet with GI GVHD, but maybe we can intervene earlier, and they might not even develop it, which would be the ideal scenario. So acute GI-GVHD. So GI-GVHD causes the majority of non-relapse mortality, and score 3 identifies the high-risk patient at diagnosis, including the patient who haven't yet developed GI-GVHD symptoms. Opportunity to target GI tract at diagnosis before steroid-resistant GI-GVHD is firmly established. So alpha-4 beta-7. So alpha-4 is an integrin, a glycoprotein that is expressed by most of the leukocytes and mediates the interaction between that lymphocyte and the endothelium, and is responsible for cell trafficking and how to go this leukocyte go to the surrounding tissue. Alpha-4 beta-7 is a cell surface molecule mediates the T cell trafficking to the intestine to an associated lymphoid tissue. Yibin Shen showed that this alpha-4 beta-7 had an increased expression in GI-GVHD on CD4 positive and CD8 positive memory T cells, and when they collected samples at onset of GI-GVHD. Here you have a slide showing that when they compared the percent of expression of alpha-4 beta-7 on memory CD8 positive T cells, they compared the patients that had intestinal GVHD and to the one that had skin or no GVHD, and a significant difference was seen, which can be understandable by the fact that this is a molecule that is responsible for the interaction of those T cells with the endothelium molecule that will be responsible to allow the T cell trafficking. So this is a cartoon. It's based on the central nervous system, where we have VCAM, which is the cell adhesion molecule, which is not the same for the GI tract. So you have here an activated leukocyte here. This activated leukocyte expresses alpha-4 integrin, interacts with the VCAM, which is on the endothelium, and then this allows the diabetes and the trafficking of that cells to the surrounding tissue. When you infuse the natalizumab is an antibody against that alpha-4 integrin and interrupts that interaction, and with that you don't have T cell trafficking. Again, in the GI tract it will be MATCAM1. So natalizumab is a humanized monoclonal antibody against the alpha-4. So it blocks, and that's where the PML comes into play. It blocks alpha-4 beta-1 and the alpha-4 beta-7 integrin. And I'm saying that because this alpha-4 beta-1 is in the CNS, and that's what have been involved in the PML genesis. Inhibits cell trafficking to the central nervous system and the GI tract. It was approved for multiple sclerosis in 2004. Was approved for Crohn's disease, relapsed refractory, non-responding to previous immunosuppression in 2008, and has been shown to be efficacious in active inflammatory bowel disease. It is currently being tested at the Dana-Farber in severe GI-GVHD. Small numbers of patients have been enrolled so far, and so far no safety concern being shown, recorded. So what are the study objectives? The primary objective is to improve the day 28 CR rate for patients that have Ann Arbor score 3 GVHD from a 30% CR rate to 45% CR rate. Secondary objectives, to decrease the 6-month non-relapse mortality rate from 45 to 35%. And also to evaluate the safety of natalizumab for treatment of high-risk GVHD. So primary endpoint will be what is the proportion of complete remission that we have at day 28. Secondary, the 1-year overall survival, the cumulative incidence of non-relapse mortality at 6 months and 1 year, and also the overall response rate at day 28, as well as the cumulative incidence of treatment refractory disease, which would also be interesting to see.
I'm sorry, maybe you said this at the beginning. Is this a study for treatment or for prophylaxis?
Treatment, the patient
So
declare
if
itself.
the patients, if the mechanism that you're proposing for natalizumab works by is to prevent trafficking of the T cells into the gut, isn't it too late once they have the GVH?
Might be.
I mean, isn't the T cells
But
are
this is
the
not-
GVH?
No, but it's a type of a progress because you're taking the patients who are going to be a high risk
50%.
based on an arbor score, which might or might
As
not
I
have
said,
IGVHD.
Yes, but this is another,
They are high risk.
so here, it's okay. So GI-GVHD is not present at onset in 50%. The other 50% have GI-GVHD.
Yeah, so, but it's not necessarily treatment only. It is also
Preemptive or if you want.
preemptive or aggressive treatment of patients with a high risk and not.
For those 50% that only have skin, yes.
So you're treating patients who have GVHD of all sorts if they have a high NR score.
Correct.
So it could be somebody with grade 1 skin GVHD with an
Yes.
3
Yes.
could get this drug.
And in that case, it was trained.
And then you have to believe. This is the moment of the believing. Okay. Okay. So, which of course you do, right? Inclusion criteria. Inclusion criteria, new onset acute GVHD, any Glucksberg rate, and I was 3. That's okay. Any donor type, any condition regimen, no prior systemic therapy for acute, except for maximum 3 days. Why? This is the window that I have to collect the blood, send to a lab, assigning the scoring, and then starting the treatment. So up to 3 days, that's fine. Because of course, if your patient has 3 liters of diarrhea, you want to start the treatment right away.
So most of our patients in the hospital are not treated with prednisone.
So you have equivalent with methylpred. It's allowed also. It's equivalent to methylpred.
So we have to be very careful because
be
I
very
think we
careful.
start with the methylpred to make per kg, not the prednisone. So we
That's right.
No,
It's
but
different.
it's
What do you mean?
different
Dosing.
dosing gonna be, so we have to be aware that we have to calculate. the
So we
dosing.
discussed that. We discussed and we're going to accept it. Don't worry.
Okay, because otherwise. So, but if you have a patient with, in the hospital that you want to give 2 kilo of IV methylpred, that's fine. If you have a patient who's an outpatient with skin GVHD.
It's going to be pred.
And you don't want to treat them that much, you just want to do
Right.
1.6 of IV or 2 of pred.
Right. Okay.
In the outpatient, we don't do that.
Exactly. So it's all included there. It's okay.
And the countdown only starts when you give systemic therapy. The
Yes.
countdown does not start when you give them topical steroids.
Correct. Because your diagnosis is, for the measure, is the same thing. It counts the onset when you start treating it as if, right? So topical steroids, budesonide, all allowed. More than 18 years old. The bilirubin has to be less than 2, except if they have Gilbert syndrome or acute GVHD within those 3 days of enrollment, right? Because then you can tell me about maybe this is liver.
It doesn't have to be the biopsy.
Do you need to do skin biopsies?
No.
No biopsies?
No.
Gut biopsy?
I mean, we do it, but it's not required. That's right. That's correct. ALT and AST must be less than 5 times the upper limit within the 3 days of enrollment. Okay, contraception, written informed consent. Biopsy of target organ is recommended but not required.
And this is going to be a separate consent from the matching. So at the day will
Yes.
be involved on this at the time of the onset of GVHD. We'll go through that.
We don't need to have them on magic. Exclusion, as expected. Cancer, which I don't even know what we are not going to treat the patient that are relapsed. Uncontrolled active infection, chronic GVH, history of PML, which probably those are dead. Dialysis or ventilator support, pregnant nursing women, they don't come to swallow anyway, use another acute GVHD drug, other investigational agent within 30 days. That might be important for some of the patients that we enroll. History of allergic reaction to natalizumab if we are transplanting a Crohn's disease patient. So, screening process. Pre-screening. Patient comes and has a new onset acute GVH, grade 1 to 4. You suspect the acute GVHD to be occurring in front of you. You collect 5 ml of serum. You send it to Dr. Ferrara's lab. And you email magicsample@mssm.edu. Ship priority, this is for the other sites, overnight to the Ferrara's lab for early AM arrival. So it's always overnight. And
So in our case,
it's right there, across the hall.
What other sites? Oh, you mean the other sites?
The other sites.
Yeah.
So an Albert score is phoned, it will be phoned and emailed to the site within 24 hours. The pleasure of Dr. You're not involved in that, it's George and Dr. Ferrara, the one giving the buzz, right?
if Jamie's away,
Or Dr. Levine. Then it can be an Arbor 1-2. In that case, it's going to be a screen failure for the natalizumab, but may be eligible for the BMT-CTN 1501, which is sirolimus versus prednisone for those that are Minnesota standard risk versus, I'm going to have a beautiful flow chart that was created by Sonia right here and Christine Wu to show exactly how it works in real life. So the Minnesota risk certification will be important for that. But if they are 1-2, they can be enrolled on BMT-CTN 1501. And then I'm going to discuss that. If there are 3, then they're eligible for the natalizumab. Okay?
What happens if something?
Nothing happens. You might miss some patients, right?
Yeah, we only do.
Yes.
So can you collect them on Monday?
Yeah.
If they present on Sunday, can you collect them on Monday? Would they still be?
Yes. Yes. I'm going to have a real case scenario here.
You know,
Those girls, they
don't
thought
present
about,
Friday night at your 5
it's
p.m.
always like this. I know.
Oh,
That's why it was
like
thought
they
about.
do.
You're right. It's like APLs. It's always on Friday night. So newly diagnosed GVH, intend to treat systemically that you have. So by the data, 80% of those GVH patients will be Minnesota standard risk. Those guys are 1501 eligible. Minnesota high risk, I even showed when I presented even with the beautiful app that has a little cap. It's based on how many organs, but it's kind of complicated. They have a different way of certifying that. You need to use the app. And there is an app. I think I already okay. There is an app for that. You just put all the data there and they tell you standard risk versus high risk. If it's high risk, it's not 1501 eligible. You begin the steroids if the patient is really, you're really concerned that it's a bad disease. Then if it's a MAGIC patient, you send a sample. Do your email, communicate. And number 3, consent and natalizumab. The patient wants to be on natalizumab, not a number 3, standard of care. Why? Because they are not 1501 eligible, right? So they cannot go back to the other arm. So steroids here, and number 3, natalizumab possible. If they are not MAGIC patient, not being enrolled before, then you consent to natalizumab and you send your sample. And number 3, natalizumab offered. And not a number 3, standard of care. So this is for the high-risk Minnesota, which is about 15% of GVHD patients. Let's look at the other side, which is the 85% of GVHD patients. Those are standard risk. They are 1501 eligible. You consent to that other, which is sirolimus versus prednisone. You send your sample, you're enrolled, and they'll randomize 1-to-1 sirolimus versus prednisone. Comes back your risk stratification. If they are a number 3, then They are not meant for the sirolimus prednisone because this is 1-2, but they can be consented to natalizumab. Start the steroid as per the protocol for natalizumab, and then they get the drug.
Like within the 1501, they're not looking at Ann Arbor. You're just.
They are. They are. They are.
So this doesn't.
It's
these are
1-2.
mutually exclusive studies then.
It's 1-2
I get it.
plus
I didn't realize
standard
they were-
risk Minnesota.
I didn't realize they were cahoots with you guys.
Okay. The patient comes in with newly diagnosed GVHD.
Yeah.
We.
You take your phone, you do the risk of Minnesota.
I just tried to find it. It's not
I'm
letting
gonna
me
send to
find
all
it.
of you
Okay,
guys.
send the link.
You call Ann
Calculate the Minnesota
and calculate.
standard
I
rate.
calculate to you, and I said
Okay.
standard risk.
And then
You pull your consent.
for 1501.
Right.
And then you can, and this happens before
Take 5
you do
ml.
the steroids.
Yeah. It has to happen, exactly, because they have to be
So the
randomized.
patients who come in on Saturday and Sunday do not go on 1501, period. But they can still be eligible for.
Listen, we're gonna miss some
the
patients.
Natalizumab. I'm just
Yeah.
want to
Yes.
make sure that we're clear.
Yes, yes, yes.
But it'll only be 20% of them will be in Arbor 3.
That's right.
So
No.
80% of the patients who are Minnesota standard risk are going to be in Arbor 1 or 2.
Right?
So if they come in on the weekend and you can't wait to start treatment, so they can't be enrolled or randomized.
On the 1501.
So you start the steroids over the weekend, they automatically become 1501 ineligible.
Right,
And they are only eligible for natalizumab.
right. If they are number 3.
Yes, yes. I
Got it?
understand that.
We're gonna miss
And
some patients.
How quickly do the 1501 gets, well, first of all, do we have 1501?
Not yet, soon.
Okay. And how fast do they get the
24 hours. No, the number score is 24 hours.
What do you ask?
No, for the 1501, how quickly do they randomize? It's 24 hours?
No, it's just, we just click the button. Literally, I think the real question is how quickly, when we're standing in front of the patient.
Yeah.
we
I can take the
know at a
decision.
standard of high. If that can happen in minutes, this makes
Yes.
it very easy to do.
I'm gonna send the link for the app.
Yes, because
I
I'm
had
trying
it
to
on
find
my-
it right now. and that's not-
It's an app, it's an app, it's an app. I had it on my phone and I deleted it.
I mean, if it's called Minnesota, then I can find it. Anyway.
It is an app.
Okay.
Okay, so I'm gonna send the link to everybody, okay?
Take an hour, as long as we have all.
At most, that's right. Because even if you have to open the link on the computer, it's a maximum of 1 hour, okay?
I just was wondering if it was the 24 hours or.
It's very quick. And I tested myself when I had the app on my phone to see how quick it is. It's really quick. So the randomization is also very right.
I was worried about like the 1 hour, like the app that you were talking about. The app is
Yes.
it's as fast as you can type the.
You have to enter all the organs, everything. How much poop, this kind of thing. So enroll, randomized 1-to-1, sirolimus, anyway. So if they're not on number 3, so they continue with the 1101 assignment treatment, sirolimus versus prednisone. If they are not a number 1 or 2, then they are number 3. Then you can consent to natalizumab. And then you proceed with that. But here is the thing. You have to start them on steroids. Okay? That includes the skin, a number 3. That might have just shoot around the neck. Yes. If you believe. 6 days. 6 days. And then you taper. I'm just stressing that because this is where, I think the major.
So I see a patient in clinic.
Yeah.
They have a grade 1 GVHD
Yeah.
rash. I don't have to do any of this.
If you don't
I
want.
just wait until Thursday when they have a grade. I mean, like.
If you
I
don't
said,
give anything.
I say,
Yes.
is that kosher?
Yes.
Yeah.
So this is
Because you're not
triggered.
going to want to give a grade 1 to a kilo.
A little
You
bit,
leave them
right.
alone and they become grade 3.
So.
Yeah.
The Ann Arbor, 20% of the patients with grade 1, 20% of the population that we did this study on to determine the Ann Arbor scores. The scores were derived when the patient was not on systemic therapy. It was almost entirely skin GVHD that was being treated with topical folate, but a sample was obtained, and those patients were being on systemic steroids at the time that the sample was obtained or not. Those patients were equally likely, if they were Ann Arbor 3, to die. So the biomarkers are telling you that the patient is high risk before the patient has may not yet have clinically declared
how bad, how sick they are.
So philosophically, one approach is it's Monday. I think this patient is clearly a GVHD rash. I'm going to draw the blood and put them on this clinical trial because that gives me a 3-day head start.
Yeah.
On
and if they're on magic, they're going to have the sample anyway.
Or you can say, I'm really not sure. I'm going to have the patient come back later in the week and see. Both options are available to you. The clock starts as soon as you start
Steroids.
But I guess what you're saying is, even in the person who has grade 1 skin, if they turn out to have 3, Ann Arbor 3, that's bad. So you shouldn't feel
It's
bad.
bad.
But you don't have to fed them.
You draw the blood. That's right.
So if they come in with like a little
Rash.
that you will not clinically will not start IV steroids, you can still send blood.
That's right, and stratify them.
If it comes back as grade 3 and normal,
Then you. That's right.
treat them and then you give them 6 days, 2 weeks per day.
So we need one of the things that we're trying to figure out today is what non-Mount Sinai sites need to understand. So we need to have this spelled out in the slide.
Yeah.
Drawing the blood.
We're real case
required
scenario.
To treat the patient yet.
Yeah, I think that's a
You
good
have to
idea.
start treatment once they're Ann Arbor 3. If you're going to
There is another.
But let me
There
ask
is.
you
Let
another
no.
question.
There is a slide for that. Let's go to the slides. Yeah, go ahead.
Let's say, this is a good example, let's say it comes in less than 25% rash. You give them steroid.
Hydrocortisone topic.
Creams, topical steroids. They come back 3 days later, their rash is gone by Ann Arbor, they're in 3.
That's exactly.
That could easily happen.
Yes.
And they would still be eligible.
Yep.
For the trial, and that you're putting your faith in. The reason they're Ann Arbor 3 is because that
Yes.
the stuff that's going on in their intestine that's driving the Ann Arbor
Exactly.
score and hasn't shut up yet with symptoms. It's appending. It's time to shut it down.
That's right.
So I also.
And it's 12 days later.
So let's say that happens, but let's just carry that out. So that happens. They get 2 mg per kilo for 6 days.
And then you start the tapering. Yeah, exactly. And the tapering is up to H1. There is a tapering that is proposed, but you don't have to follow it. Yes, it is.
I would do 2 days, 6 days, 6 days per kilo.
You're buying exactly that. You're buying that.
Wait. But it's not just 2 weeks per day.
What do you mean?
Plus the natalizumab.
Oh yeah, Natalizumab also.
You give natalizumab to someone who has no symptoms whose rash went away based on that.
Yes.
Based on I don't know what the number
That
is.
is more of a problematic.
Which one? This one or this one?
How many
Chance of
doses?
getting the skin only slide.
This guy, the
The
skin.
next slide, the next
So
slide.
the next slide, exactly.
Based on a 30% chance
Yes.
of getting, is that severe lower gut or is it any lower gut?
These guys here on the red,
What's the different colors?
because this is a number 3, a number 2, a number 1.
Right now, but the colors don't mean anything. It says Ann Arbor 1, 2, 3.
Yeah.
So a 30% chance of getting lower gut, like that lower gut? Any lower gut?
Any.
Yeah, no, I see what you're saying.
Yeah, but
How many doses of natalizumab? 2 then?
I think that the thing, Paula, is we've all had patients who come in with mild skin rashes that we put topicals on and they go away, and those patients from
Yeah.
refractory.
We know that. Yeah.
This test, this blood test, is helping us identify some of those patients. But
That potentially do bad.
I will put the patients on. You've sold
You
me.
promise?
I promise.
Okay, she's
I
good.
just-
We have her.
That particular situation, I think, will give not a pause.
And again, let me say
Not-
something.
not just
The
me.
Dana-Farber is using it, and they already enrolled a few patients through, but with no significant side effect.
What On this study or on the
GI.
That's a very different story.
Well, I mean, they could have other.
We need another slide that specifies patient with a skin rash that gets treated topically and
Yes.
gets better, but is Ann Arbor 3
Right.
is eligible,
I think, yeah.
but they need to.
I agree. That's a
steroids
nice
for the
slide
days
to have,
plus,
yeah.
That's
Because the
that's
real
exactly
case
it.
scenario, absolutely.
Nobody has any problem giving natalizumab to somebody who's got GVHD.
No, that's easy.
Absolutely not.
We might even ask. An number 2 came, right, score 2, but the guy is pooping, we might even ask for it. Okay, so going back.
Can you just very quick, I'm so sorry. I know you've said this in previous
That's
presentations.
okay.
What is the difference between natalizumab and natalizumab?
It's exactly the targeting. One is alpha 4 beta 7, vedolizumab, and natalizumab also targets the other one, the alpha 4 beta 1, which is CNS. That's the problem with PML, because it targets alpha 4 beta 1. The vedolizumab only targets alpha 4 beta 7,
So why are we not?
because the pharmaceutical company doesn't want to give it. Make sense?
And we're not excluding the patients that we know are JC positive.
We
When do
spoke
you know
about
that
it.
it's on?
We can run it.
No, I don't know how. I have never asked
If
for the JC.
But we could.
But there's
We could.
somehow some of my patients, the JC virus gets sent, and I
Yeah.
know that they're positive, and I.
So let me just say, I'm going to have a slide for that, but let me tell you right away, JC virus positivity is very prevalent in the
Yeah.
community.
I know.
It's about 80%,
I-
number one. Number two, they already did the screen to see how much would get, not get. So the risk factor to develop a PML has been shown since they were approved. The cases that would interest us is 2 cases with Crohn's disease and 1 case that had multiple sclerosis. After they opened that and they had, the surveillance after that, no further case was
Did
got
they
it.
exclude the JC virus? Did they look at the JC virus?
So let's get to the slide because I have it there. Okay. So no. Okay, I went through that screening process. We went through that, right? Okay. We were there. We went through that screening, enrollment, and example. Systemic treatment can wait. So this is I had made one change here. I was just I had boldened the mild. So this is a patient with mild symptoms of acute GVHD on a Monday onset. You take your sample. You might decide to treat or not to treat. You send the sample, which is another issue also when you suspect upper GI GVHD. You don't always start budesonide the day that they come with nausea and vomiting. Or not even. Sometimes it's only nausea. They lost 1 kilo. You wait. So research sample is sent to Ferrara's lab in New York on that same day. The email is generated, everything. And the next day, latest, you have the Ann Arbor score that is assigned. So onset +1. Complete eligibility and enrollment on that same day in the afternoon, so onset +1 still, or Wednesday in the morning, onset +2. Begin the steroids and the natalizumab that day on Wednesday, onset +2, or the Thursday. This allows you, if it's an outpatient person, you can call the patient. So Thursday, you're still onset +3. You're still good to go. And this becomes the study day 0 because it's the day that you start the study drug. I'm saying that because sometimes it's confusing with the day of the onset of GVH and everything. Ann Arbor scoring is available Tuesday through Saturday. Same logistic is used for BMT-CTN 1501, which is Minnesota Standard Risk Ann Arbor 1-2. Yes.
Relative to 1501, if they get randomized to sirolimus, once they become eligible for that natalizumab, what do you do with sirolimus?
Stop.
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 And start pregnant. Okay.
You stop.
And for 1501, if they already have tacrolimus, you add sirolimus to tacrolimus and not give the steroids.
That's correct.
Okay. And what is, I'm sorry if you probably said it and I missed it. From day 0 of the transplant, up until which point are the patients eligible for the study? Like it's within the
Acute, yeah, when they come.
Yeah, but break. Acute can be 6 months. Oh, so we are not talking. There's no time frame after the first. Yeah,
That's right, exactly. So
Say that?
this is the other case.
So you have to point that out.
Yes. This is the other scenario. Severe. Patient diagnosed with severe symptoms of acute GVHD. Most likely this patient will come to the hospital, right? So it's less of a problem. You send the onset sample on Monday. You start the systemic steroid that same day because they had severe disease, right? Or you enroll because everything is triggered at the same time. You're going to do your Minnesota stratification. You check if they're standard risk, they're eligible for 1501, right? At the same time, you send your sample to New York. You get to see if they 1 or 2, and then you click the button for sirolimus versus prednisone. If they are number 3, natalizumab. Research sample sent to Ferrara in New York, right? With notification that steroids have been started. If you already started the steroids and you have not considered that, so that it's over, right? If you decide. Another score is assigned on Tuesday on set +1, and then complete eligibility and enrollment on Tuesday, that same day in the afternoon, or the next day in the morning. Begin same thing. Begin the study treatment on Wednesday on set +2 or steroid +2 because you're allowed to 3 days of steroids, or the Thursday, which is on set +3 and steroid +3. Same thing. So you have time, just to show that you have time, even if you have started the steroid for natalizumab. So another score 3, prednisone 2 mg per kg or methylpred equivalent. Natalizumab 300 given on day 0 and day 14. And then CR is a success. On day 28 you assess it. Whatever else is not considered a success. Always remember natalizumab is started within 3 days of steroids. Systemic steroid therapy can be given up to 3 days prior to the first dose of natalizumab. So you can also count by day -1, -2, -1, and day 0.
And the CR does not take into account the ability to take patients on steroids. CR just clinical CR.
It's based on organ response. Sometimes you have to taper very slowly. The tapering is another issue.
But what if you're not, I mean, does this trial take into account the ability to take someone off?
Not that I'm aware. No. That's another totally different issue. Because no, you're going to see also how much of them relapse in terms of GVH when you taper them off. So this also will be counted. That's going to be there as also analyzed. Yes. It's proposed. There is one proposed on for the BMT CTN, and I even did a copy of it just to tell you exactly what is proposed. But it's not mandatory because also sometimes the patient is doing so well that so it's 2 mg per kg per day prednisone until the day 6, which is the important one. Then 1.5 from day 7 to 13, 1, 14 to 21, 0.5, 22 to 28. So they're still on steroids on day 28 if you follow this one. Okay? So this is the trial design. The only thing, the GI biopsy, just to mention, it's optional. And because if it's done, they will look into it also as part of the study. Okay? Treatment plan. Steroids plus natalizumab. This is a treatment plan. So steroids. Initial steroid dose must be at least prednisone 2 mg per kg per day orally. Or methylpred. Again, 2 mg per kg per day of methylpred is also allowed. Steroids cannot be tapered before 6 days after administering the first dose of natalizumab. After the 6 days, follow the local institutional tapering practices or this one that we propose.
I think we should probably change that slide so it says follow the proposed guidelines for tapering or institutional practice.
Okay.
Because we actually specify the protocol.
True. That's true. Natalizumab is given day 0, day 14. Natalizumab must start within 3 days of starting the steroids, and the date the first dose is given is considered the day 0. Dose modification guidelines, second dose of natalizumab is administered on day 14 of the study. If toxicity develops that pose an acceptable risk, you hold the second dose and remove the subject from the study. If for reason other than toxicity, for example, comorbid condition, the second dose cannot be administered exactly on day 14, you have an acceptable window from day 12 to day 16. Okay, 48 hours. Fine.
If their GVHD is not responding and you just want
Whatever you feel, whatever you feel. Something.
They're doing really awesome.
They have to have surgery on day 14.
They want to go home on day 14, right? And you cannot adjust the outpatients. Just give it before. Then graft. I don't know, whatever. So this is the safety measure, and I put all together, you know, the data for that. So over 100,000 patients treated since FDA approved in 2004. No safety issues seen so far in the small number of patients that in the Dana-Farber for natalizumab for severe lower GI GVHD. Progressive multifocal leukoencephalopathy, which is the PML. It's rare. It's really rare. Risk factors are. So this is also very important. Those patients that developed it, they were at higher, they developed it because they were 25 months, most of them they were more than a year on immunosuppressors. They had multiple lines of immunosuppression before. Okay, this is also very important to mention. So risk factor is prior immunosuppression, obviously to have positive JC virus antibodies.
These are not transplant patients who got this. These are arrests.
That's right, exactly. Multiple sclerosis and Crohn's disease. One multiple, not that I'm aware.
I'm just wondering what else they got that might have been
Methotrexate, I had a
Our
list.
patients are gonna be way more immunosuppressed
Exactly. They don't get,
than
yes, absolutely. Because they get a lot of infliximab for Crohn.
Well, yeah, they wouldn't have received the prophylactic GVH therapy, but they would have received.
Yeah, but we're giving these guys steroids, all of the
Yeah.
But let me just say one thing. It's true that for the vedolizumab, they don't want people that receive rituximab.
Yeah.
Because some of our patients, I see the point. The point is relevant. Some of the patients. Yeah.
We're underestimating
Right.
the real risk by 100 times.
So the data is initially, so what is in the literature, which I have collected? So PML, initially developed in 2 patients with Crohn, as I said, and 1 patient with multiple sclerosis. In the real life studies, Crohn patient, no case of PML was recorded so far as a publication 2013. The most frequent side effects were headache, low rate of infusion reaction, and 9% incidence of antibodies development against the natalizumab. Except for the 2 cases in PML in Crohn's, all other reports concern subject with MS. Okay, so they have 99,571 MS patients treated with natalizumab until February 2012. 212 confirmed cases of PML are reported, which is an 212 from 99,571 cases of multiple sclerosis patients treated.
They're still using this drug.
No, they are going down and down and down and down. That's a, I mean, this is a parallel discussion.
There is some.
It is
The
approved.
last time I've looked at, which was a while ago, of the JC virus and possible relation to MS. So
It's a concern. It's a concern.
Majority of them are. So okay, are we testing for the antibody development between the 2 doses?
So, sorry?
Or not?
So let me tell you, what is interesting also, so it increased, so the risk is 11.1 in 1,000 subjects that have presence of antibodies. And if they had immunosuppression treatment before starting natalizumab, and the duration of that therapy was more than 25 months. So this is not our patients. I just want to, that's why I've collected that. And this risk, even for that population, is 4 in 100,000 if they had more than 12 months of immunosuppression prior to natalizumab, okay? So what else? Infections. No increase in other infection, including the Crohn's disease patient that concomitantly treated with immunosuppression, steroid, methotrexate, and 6-MP. Hypersensitivity in Crohn's disease, less than 1%. Malignancies, also they look at it, no increased risk. Stopping rules, PML. Pause study if one case of PML develops. If internal and external DSMB and FDA agree, trial can continue, revise consent, disclose to the potential subject that PML was observed, and then you can go again and terminate the study if two cases develop. Okay? Grade 3 infection. Severe BMT-CTN grade 3 infection during the first 2 months following graft-versus-host disease diagnosis was 24% in an over 3 patient. This is data from Michigan. Pause study, if at any point the incidence of grade 3 infection is higher than those 24%. Decide whether the study can reopen or not, knowing that already there are no increased infection that was recorded already in the marketing reports. Grade 3, so it's severe VZV infection, CMV and organ involvement, EBV, so PTLD, adenovirus, other than just the cold, viral reactivation, okay? Everything is being monitored. Bacterial, so sepsis, severe sepsis with bacteremia, fasciitis, I mean, everything that is bad, right? Adverse event reporting requirement. The adverse events reporting period begins with the first dose of Natalizumab through 30 days after the last dose. Okay? All adverse effect grade 3 or higher must be reported. Grade 1 and 2, no need. Any increase in severity, toxicity grade of a pre-existing condition that occurs after the start of study treatment must be reported, if grade 3 or higher. Conclusion. Major data coordinating, so John Levine, James Ferrara, Rachel Young, George Morales. Those are the 2 emails that you need to remember. And that's it.
Where are you? Next slide. Where are you?
Next.
One more.
One more? Okay. One more?
Good job.